our patient, you know, feels humiliated. So we kind of need to provide that education and support to say, look, you know, it's not, they're not intentionally trying to be difficult. This could be a real problem. And this is how you communicate well so that everybody feels dignified and supported. Next, elder abuse prevention. You know, it's in those early stages of memory decline and functional decline that oftentimes people will be taken advantage of, especially with regards to financial elder abuse and other things. So right away, we realize there's a problem. We want to put into place those safeguards for the patient and family so that they're not, you know, vulnerable to those that would take advantage. You know, and finally, the resources. There's so many community-based organizations out there that are willing to help, that sometimes the caregivers are just really in need of resources that we can provide. And also providing safety. So many times we found out that we have persons with dementia who may get confused at night. They may actually wander outside the home. They may not be safe using the gas stove, for instance. And so these are all really key elements to address when we know that there could be a memory problem. So lots of convincing evidence not to wait. And a couple more slides before we get to the case. We just wanted to make a distinction about, you know, what's normal aging and what's not normal aging. So normal aging, in the broad overview, it really doesn't affect one's ability to live their daily life and to be functional. You know, they're still managing their finances, they're managing their appointments, they're, you know, functional in the IADLs, they're interacting with the community and thriving, okay? They may have, a person with normal aging may have subjective memory complaints, so they just can't remember names the way they used to. And it's annoying, but certainly not disabling. They may not recall detailed events quite as easily. And the speed and efficiency of that information processing is definitely, you know, the processing is still intact, but with the speed and efficiency that they use for memory recall is somewhat slower, but it can come back. So this is somebody who's kind of like, we might call them the worried well, or, you know, they come in and they say, I'm really worried. I can't remember, you know, this actress's name, or I couldn't remember my nephew's birthday last week. But, you know, but for all intents and purposes, they're living a good life. They're independent, they're thriving, and there's no, you know, significant issues. So then we move into mild cognitive impairment. Over the past few years, this has really been redefined and redefined. The most current definitions or categories that we have include amnestic MCI and non-amnestic MCI. Amnestic MCI is MCI that really affects the memory, you know, and that's the most significant complaint. They may start to forget important information, such as appointments, conversations, or recent events. And this would be in excess of the person with normal aging. And we can find this by testing. Now, on non-amnestic MCI affects, their memory may be intact, but the ability to have insight and judgment, or to follow a sequence of events, you know, such as complex tasks, may be affected. So you can see that different areas of the brain just aren't working very well. But again, it's not to the level of a dementia where they're really starting to have more than one system affected at a more significant level. Now, the thing about MCI, and we feel like 1/4 of people over 65 may have MCI. So again, the prevalence is really, you know, startling. May or may not progress to dementia, and we still don't know how many. We don't know in what situations. There have been situations where people just stay at the status quo. People may improve, or they may progress to dementia. So that's still really being researched. And then finally, we have outright dementia, which is specifically defined as an impairment of memory affecting, so it's bad enough to affect function, and at least one of the other following cognitive deficits are affected, right? So it could be language, it could be apraxia, it could be agnosia, it could be executive function, you know, and again, that would include the insight, the planning, the complex tasks, and so forth. And so you have to have a memory, again, affecting function, and at least one other, you know, neurological sort of category, which is impaired. I just threw in an image up at the top of an MRI showing a normal brain on the left. And you can see that, you know, there's very, very little airspace in the ventricles as compared to the one on the right, where you can see in the sulci and the ventricle areas, there's just so much more lack of tissue in the black areas, you know, denoting open space. So clearly this is a disease process, and you know, we can measure it in very many different ways, and we'll be getting into that in following sessions as well. So the basic distinction between normal aging, MCI, and dementia is one that we really want to reinforce as we go through the next few sessions. And you know, the impact of this on people, I mean, it's just devastating. This is one of my favorite quotes from Tennessee Williams, and it says basically, life is all memory except for the one present moment that you're living now that goes by so quickly you can hardly catch it going, and then it becomes a memory itself. So this really strikes at the heart of, you know, who a person is, eventually eroding personality. And in that sense, it's just really the most devastating disease, I think, that we treat as caregivers and providers of older adults. And then one last slide about the 4 M's, because we have built this series around the 4 M's. For those of you that haven't heard about the 4 M's, they're kind of our geriatrician way of telling people what we do. Okay, so we are also on the way of building our own health system into what we call Age Friendly, which is a national initiative. And if you all are interested in learning about it and maybe moving your clinic or your setting towards age-friendly status, it is well worth it. And it tells the world that basically when you take care of an older adult, you are paying attention to their mobility, their mentation, their medication, and really person-centered care, what matters most. If you'd like any more information on that, Nika's our expert, and she can provide that. But just to say that we've also geared this series so that each hour after this one will be dedicated to one of the 4 M's as it relates to dementia. And I have a chat here from Candace from Mammoth. Thank you. She said, please, would love to have that information. So we'll send that over to you. And anyone else, just let us know.
Sure, happy to.
Okay.
Thank you so much, Dr. Gibbs. Do we have any questions for Dr. Gibbs?
And if not, I think we can move into our case.
Okay, wonderful. So let me pull this up. We do have one of our folks, Dr. Yassine Houbi from Aspen Medical Clinic in Calgary, Alberta, Canada, who submitted a wonderful case. And Dr. Houbi, we'd love for you to give a quick overview of this case, and then we'll kind of move into discussion. I'll go ahead and pull that case up if that's okay with you, Dr. Houbi.
Absolutely, absolutely.
Okay, 1 second, please. Okay, you can go ahead and give us a quick summary of your patient.
Sure. So this ID case is 920, as you told me. He's a 74-year-old man. He resides in Calgary, Alberta, Canada. He has an Alberta Health Services care. You know, as you know, in Canada, the healthcare system is public. It's free, actually. People don't pay for anything, for any CT scan or MRIs or any blood test. It's all free. He has a history of dementia, depression, anxiety, atypical Parkinson, type 2 diabetes, hypertension, heart disease, BPH, and overactive bladder. He came to the clinic 2 weeks ago with his daughter, who's a pharmacist. She was concerned about him being more forgetful. And he has like worsening mood swings. He has some hallucinations and talking about things that are not there. She was concerned about that. In terms of functionality, she had no concerns about his functionality. The only thing, like however, he requires 24 hours, observation, except for feeding, and in terms of ADLs. In terms of IADLs, he's like really fully dependent on IADLs. The test the test we did, he had like a MOCA test in 2016 was 19/30. Recent get up and go test was over 12 seconds. In terms of the past history, last year in 2019, he had several problems. He was at the hospital in July last year due to hallucinations, confusion, frequent falls, decline in functionality, and worsening depression. They did for him like everything: lab, CT scan, MRI. They were all like normal, except for MRI. It was suggestive of Alzheimer. The treatment at that time was they adjusted his medication for Parkinson, and they removed his lorazepam that he was taking for anxiety. So his mental status and delirium resolved, and even his hallucinations and confusion, by adjusting just his medications. And OT, PT were on board, so he was prescribed a cane at that time. So he was stable since last year until like 2 weeks from now, 2-3 weeks from now. Again, he came with a bit of confusion, more forgetful, more mood swings, and hallucination. So to me, what I did when he came, I know that he has a bit of dementia, but he came with with those new symptoms. To be honest, I just increased his escitalopram from 15 to 20 milligram. He's on 20. This dose change is new from 15 to 20. He has a Parkinson specialist, and he has supposed to see him like maybe 3-4 days after he saw me. So I have not done any other test, any other like change in his medication. I just left that to his Parkinson specialist just in case we need like extra medication changes, or he has to add some other medications. And I did for him myself blood test. I ruled out like some other causes of confusions, or just make sure his thyroid is okay, and folic acid, vitamin B12. I just got the result of labs just yesterday, were all normal. And I haven't seen him ever since. So I'm just waiting for the specialist to see what his opinion, and to see what's my medication change of escitalopram increased like from 15 to 20 to see how he does. I told him to see me like in 2 to 3 weeks, and I'm just waiting for him to come in. So that's my case. Hopefully it's clear,
That's great. That's really a rich case. Thank you.
Thank you.
Yeah, I guess we could start off with people's questions. One question I thought, in terms of atypical Parkinson's, could you say just a little bit more about why it's atypical in terms of the neurological presentation?
Yeah, just maybe because of hallucinations, maybe the type of movement that he had, the falls that he had, the tremors that he had. I think that's what he was diagnosed by his neurologist, actually. That's what they say, atypical Parkinson.
Can you describe the hallucinations that he's having?
you know, the daughter, she said that he was talking about things that they are not there. Like, you know, talking about things that they are not there at all. They sit down and talk about things. So that's what she told me. So that's what she thinks, like she described as hallucinations. But I don't think he was like hearing things that are not there, but talking about things that they are not there. Maybe that's what she thinks about hallucinations. And he was confused as well. He was just, he doesn't know maybe where is he, with whom he was.
Okay.
That's what I understood from the daughter.
And
Yes.
then just one additional question. The
Please.
cognitive impairment that you described with the MoCA of 19,
Right.
was that done at the time of diagnosis? Was his cognitive impairment there before the diagnosis of Parkinson's, or did the cognitive impairment develop after?
Actually, that's the first time because he has a different family physician, and I got him like, you know, 4 years ago. And I was reviewing, like, if you can see my case, well, you know, I didn't present all my case because today morning, actually, I went to all his records and I gave more information just to give you the right information and see what's going on. But I found from his record that the only MoCA was done on him was in 2016. Yeah. And I haven't done on him any MoCA because, you know, of the time, because we go here like by 10 to 15 minutes appointment. And I didn't have really time to do that. And my plan was to do on him like more testing next time when I see him.
And I'm sorry, last question, and then I'll let someone else.
No, absolutely.
The change, this increase in forgetfulness and the hallucinations, worsening mood swings, what time frame did that develop over? Was it acute, or had that been going on for some time?
Yes, actually, the daughter told me like over the past few weeks, it was like getting more.
Okay.
Because, you know, whenever I see him for the past like 2-3 years, how he's doing, how he was doing, okay, how's his memory stable. But seems to be it was like more, like even more for the past few weeks. It's not like overnight, just a few weeks.
Thank you.
Welcome.
I have a question.
Please.
So can we pull up the medications?
Yes.
So the Vesicare, the sulfenacin, how long has that been on the list? And is that effective for him? Because a lot of these urinary antispasmodics aren't terribly effective, and they potentially increase the risk of anticholinergic effect.
Yes, actually, that's right. He has been on medication like maybe for a few years actually. And one of the his daughter's concerns that he has to go to the bathroom even more often. And she told me to give her some other medications. I told you know what, it's better to wait for now because that might even affect his memory and affect like his delusion or whatever hallucination. So it's better not to give him anything right now and wait for the specialist to see him. So I told you know the only thing I can do for you is increase the escitalopram for you.
So
yes.
So they're not. The patient is not currently taking sulfenacin.
He's taking that.
He is taking that. Okay.
But she was asking like to have like more medication or increase the dose even. I said no, I will not do that because this might make the case even worse.
And in your workup of the patient, did you include a urinalysis to rule out UTI?
Of course, yeah, I have. Yeah, I did like everything. Urine culture even.
Okay,
Right.
thank you.
Another question about medications. Do you think does he report that the Sinemet is helping?
You know, as I said, like last year actually he was even on higher dose.
Mm-hmm.
Yeah.
And when I presented like the case, I told you like, you know, they adjusted like his medication, they reduced the dose. And he was also on other medication called, I don't usually, prostaglandine. I don't know if you use that in USA here.
It's for Parkinson?
Yeah. Prostaglandine. Do you use that?
Tanya, do you know?
I'm having a hard time understanding what Can you type it into the chat
Yeah,
maybe?
yeah, actually here. Procyclidine. Here. Yes. I didn't
While
give-
Tanya's doing that, can I ask a couple of questions?
Oh yeah, absolutely.
Has he had any falls at all? Hit his head at all?
No, but he was at risk for fall.
Right, right.
Actually, he lives with his daughter, that she has, I think, 3 or 4 children. So always like there is somebody at home there for him. And whenever he goes and moves, always like he's from Pakistan originally, those people, they really care of those people. They are just, for him, for granddaddy, and those. So I have never like remembered that he had a really fall,
And simple question about constipation. Any constipation on him?
To be honest, I haven't asked about that, but if there is, they would have told me. No, I did not ask, or they didn't tell me about that.
Okay. And did anything happen 2 weeks ago? Any losses? Anything happen 2 weeks ago?
No, 100% no.
Okay. Thank you.
But I know the family very well, so I know all of them. I know all their sisters, brothers, granddaughters. There's nothing really in the family happening. No.
So were you going to type in the medicine in the chat so I can
Yeah,
see?
this is like a weird medication. Like I have never.
Okay.
I think the medication was given to him. I remember like last year he was in Pakistan.
So it may not be.
He was last year in Pakistan. So after he came back from Pakistan, maybe like a little bit, he told me like what happened to him. After he came, he was confused. So we thought that there's a change in the situation from Pakistan to Canada. But seems to be like give him like weird medication that we removed it for Parkinson because his Parkinson got worse. So they increased his medications. They added one more medication. So maybe that's what makes him like really, confused and hallucinating. So they removed the one I'm gonna type for you right now. They reduced the cinnamon, and then his situation got better. Because as you know, those medications can cause hallucinations sometimes and confusion. So we have to be careful.
And we have somebody in the chat asking, how is he sleeping at night?
He has insomnia actually, and he was taking lorazepam for that. That's why last year we removed that because he was taking that for anxiety and for insomnia. And that was causing for him like just some confusing. So just last year when he was admitted, we said we'll not give you this medication anymore.
Is he taking any over-the-counter medicines or herbal products, supplements that?
The only thing I think, let me see, because I have
nothing
vitamin D.
Nothing with an antihistamine over-the-counter or valerian root or anything, any herbal things that.
I am not aware of any of those, and I don't think like his daughter, because his daughter is pharmacist, I don't think she's going to allow for him to take any of those. Yeah.
That's true. That adds
Well, I don't know. There's some pharmacists who do integrative medicines. They do all kinds of wacky things.
I don't like she's because I know her very well. She's also my patient. I don't think she's like goes that way. So.
Okay.
You're a true family physician. You take care of the whole family.
Yeah, like from grand like fathers to the whatever.
That's wonderful. That's great. Do we have any questions from our other participants?
That's a medication. I don't know if you heard about that. Like
where?
Procyclidine.
Okay. I have not heard of it, but maybe let me look it up.
Yeah, if Dr. Gervich hasn't heard of it, then it's not a very common medicine at all.
That was given by him in Pakistan, actually.
Okay, so I don't know that it's available here. It's an anticholinergic drug for the treatment of Parkinson's.
Oh, maybe it's sort of like a Amantadine here.
No, I think it's like a Cogentin or Artane.
Oh, okay.
Anticholinergic, which would explain why he was more confused on that. That would make sense. We don't use it here.
So what we're seeing in terms of the atypical Parkinson is that the Sinemet dose was actually reduced, and this other Parkinsonism medication was taken off because it wasn't helping. So truly not like a typical Parkinson. And, you know, in a typical Parkinson's dementia, you know, may already know this, but the memory problems really occur later in the process. So this truly is very, very atypical picture of a movement disorder and a memory disorder.
Can I ask another question? What's the history of this pancreatic mass? I don't understand that. And do we need another MRI to make sure he doesn't have something else going on in his brain?
Yes, actually, you know, we are following actually up on this every year as recommended by radiologists, and it's time right now to do another one, but it's not a cancer actually. It is not, it's a benign mass, which I follow up on that. I didn't forget that.
One additional question for me, are his blood pressure and diabetes, are they well controlled?
Yes, and his last A1C, I think today I saw it was 7 point something. Yeah, so it wasn't like an 8 or something, around 7, which is like at his age, I think it's a good control.
And has he ever had a heart attack or?
He had MI, yes, he had MI. I think I read that in here. He had MI in 1990s.
Okay. Do you think that he would be able to express, if he were having chest pain, would he be able to express that?
I think he will do that. But here in Canada, I always like send him to a specialist, to cardiology, every 1 to 2 years.
Okay.
Just to make sure, you know, as you know, like here, the healthcare systems like for free. People don't say, I don't want to go or so, or do MPI or so. I just send them, I said, you know, how about we send you like for your annual like cardiology checkup? People are happy to do that, you know.
And the reason I ask is I actually had a patient who had worsening behavior and cognitive status, and that we did a complete workup, and it was due to an MI that he wasn't able to express he was having cardiovascular symptoms, and we did an EKG and it showed that he had had an event.
Maybe when I came in, I would see when was his last cardiology checkup, and I would maybe like do on him, like I would send him again to or cardiac workup, or send him to cardiology again.
And then
yes, please.
Sorry, my only other question was, does he have urinary retention? I mean, it looks like he has BPH, so he's on tamsulosin, but is there any chance that he's retaining urine and then he's kind of leaking because of the retention that he's got? Sometimes with bladder retention, constipation, you know, you can see some worsening behaviors as well.
To be honest, I'm not sure. So because of the time limitation, I didn't like dig into his case like too much. So I think maybe when they come, I have to look into the notes that you told me about the cardiac evaluation and constipation and urination. I'm gonna evaluate that more. Maybe do ultrasound for his abdomen, for his pelvis. Evaluate, yeah, for retention.
Yeah. Now, I know we're running a little bit short on time. And Nika, we have about 3 more minutes for the case. Is that right?
Correct.
Yeah.
Okay. So I just wonder, has any other consideration been given to other types of dementia yet at this point?
A question for me or for audience?
Yes, for you. Has anyone ever posited any other type of dementia? Because this is sounding a little bit like a different type of dementia that we're thinking about, I think. But I just wonder if along the way, the neurologist or anyone else has given you any indication aside from atypical Parkinson's disease.
No, actually, he was diagnosed by a neurologist for atypical Parkinson. As I said, he had last year the MRI and CT scan, and they say, you know, suggestive of Alzheimer. But from MRI, like for MRI, I did not. There's nothing like other than Alzheimer, suggestive of Alzheimer. So yes.
Oh no, I mean that's you know, interesting, because I think this, and if I can read Dr. Sagel right, and some of our other team members, it's sounding a lot like a common dementia called Lewy body dementia. And if that, you know, it's in Lewy body dementia, it's the memory problems basically present earlier, or even with the movement disorder. People have hallucinations, you know, and typically, you know, the medicines that we normally use for Parkinson's don't work very well. I don't know if anybody else wants to add to that, or if you think I'm off base, but that's something that I would really recommend the neurologist consider very strongly.
Dr. Gibbs, do you think he would benefit from some other advanced imaging to kind of parse that out?
I think really, you know, before going on to really specialized imaging, I think to just re-looking at him with the view of a possible Lewy body dementia, and then putting those pieces together would probably be the most efficient and beneficial. But Dr. Sager, were you about to say something?
Yeah, no, I was just going to say, Dr. Gibbs, I agree with you. I think because the hallucinations and cognitive impairment is very prominent for him and did occur early, it sounds very much like a Lewy body dementia. And sometimes with patients who have Alzheimer's disease and cognitive impairment and hallucinations, if they're particularly bothersome to the patient, we might consider using an antipsychotic medication to manage that. But in a Lewy body patient, we wouldn't want to do that. But it does very much sound like a Lewy body dementia, particularly if these are visual hallucinations that the patient describes vividly.
And yeah, and again, they don't often improve with the typical medications that are used. And the atypical piece, you know, could be some cogwheeling, it could be hesitancy, it could be a lot of the Parkinsonism signs that go along with that. But one of the key features is that the memory issues present much, much earlier than they would with a person with Parkinson's, whose memory issues would present years after diagnosis, typically. I think Dr. Gurvich, did you want to say a little bit about the medication list?
Well, so when I look at a med, I always try to see if I can eliminate something or consolidate. And so, like looking at the blood pressure medication choices, Adalat, for example, it's a calcium channel blocker, and it's actually, there's some evidence that it can actually cause or exacerbate GERD type symptoms, so completely unrelated to what you guys are talking about with dementia. But I see pantoprazole also on the list, and long-term pantoprazole can lead to all kinds of problems, B12 deficiency, increased risk for fractures, calcium absorption problems, magnesium lowering. Nifedipine specifically is associated with GERD-like symptoms. I emailed Nika a link to an article that talks about that. So I see those calcium channel blocker with PPI cascades all the time. So I wonder if the Adalat the dose could either be lowered, the ARB maybe dose could be increased a little bit and kind of blood pressure managed that way. Maybe we won't need 40 of omeprazole, maybe we'll need 20, or change to an H2RA blocker. The other thing, with tamsulosin, sometimes because it improves flow with BPH, it can cause frequency. And so there's obviously a cascade with that, and the Vesicare, which is anticholinergic. So if he does need so a lot of these bladder antispasmodics don't work very well. So it's a question of bladder training, regular bathroom breaks. Those behavior changes seem to work much more effectively. The other option with meds would be to try something like a beta-3 agonist, like Myrbetriq, but that can raise blood pressure, so you have to kind of keep an eye on that. So that would be my.
Yeah, the only other issue too is really if the Sinemet is helping or not. If it's really not helping, that might be a medicine that could be discontinued as well.
And this is the smallest dose of Sinemet you can give for it to do anything. So if it's not doing much, you could completely discontinue it and see what happens.
Sure.
we've actually thrown a lot at you all at once. I think we just couldn't wait to talk. But what do you think about some of these ideas? And do you have other questions? I think we have about 5 more minutes.
No, I think, I got like, new ideas about like, we have to take care of his, if there's kind of constipation, urinary retention, maybe see the neurologist, what his opinion, his neurologist, and maybe I can see what he does, or maybe myself, I can remove the medication for him, or reduce it gradually, and see how he does in terms of memory and confusion and hallucinations, But
Yeah,
this,
the thing about, of course, with any of these dementias, there's really no cure for, and if it is Lewy body, we'll see. We'll be interested to speak with you next time to see if they thought that was, if they agreed with us. But there is no cure, and there are very few medications that really help the symptoms. So then it becomes more of a different conversation with the family. And sometimes families are very relieved that at least they can, finally rest, that they know what's going on, even though there's no cure. But then it just becomes a different scenario in terms of, the care.
yeah, I think those family, like, I don't think they believe in nursing home and what send them somewhere. They just like them to stay home, I think that's what they do.
Thank you so much for bringing that. That was really a perfect case to start with.
Thank you. Thank you
Yeah,
for having me actually, and accepting me like in the program. Really,
we love, absolutely.
Thank you.
Nika, I realized we took you up to the top of the hour, but did you want to have any last words?
Yeah, I just have some closeout items. This is, as I mentioned, CME accredited. So if you do want to receive CME credits, I have marked your attendance, but it would be helpful for you to complete the evaluation at the link sent in my previous emails, as well as in the agenda I sent yesterday. I will also send a reminder after this session, so you have the link. Please be sure to complete that evaluation. Usually once we submit to the CME, you'll receive a CME certificate in your email about a month later. And please be sure when you signed up to be a part of this program, we are asking you to submit cases. So please be sure that you do submit a case. We are taking them on a rolling basis. So I have sent the case template in the previous emails, which I will also send out again. So we are looking for cases for our next session, which is in 2 weeks. And these are our future sessions. Our next one is on September 25th, again at the same time on Friday, 12 to 1 Pacific Standard Time. And our focus is going to be on mentation, the types of dementia and the differences among them. On October 9th is our medication session, and Dr. GeroECHO will be our main presenter. Next will be mobility with Dr. Wall, and the last one will be hosted by Camille, which will be on what matters most. Does anybody have any last minute questions or
Nika,
anything for us? Yes.
Nika, I just wanted to say there's a couple questions in the chat regarding valerian root melatonin. I think in the interest of time, next session is medications. I hope this will be okay, but maybe we can answer those questions at the next series, so it fit right in.
If you
Sure.
I can, if you send me an email of the person who asked, I can respond, because the medication session is in 2.
Yeah, that's fine. Yes, so we can do that.
Okay, I will go ahead and share Dr. Rod's email with you, Dr. GeroECHO, so you can answer her question. Okay. Thank you, Dr. Rod, and thank you, Dr. GeroECHO. Does anybody have anything else before we close out? And we hope to see you guys on September 25th for our next session.
Right. Thank you all for joining.
Thank you so much.
Take care. Bye-bye.
Thank you.
Thanks.